You are now listening to the HiDef Performance Podcast, hosted by Mitch Harb and Zach Smith. All right, Dr. Garcia, thanks again for coming on the podcast. We appreciate having, like we talked a little bit off air just prior. I've seen you do a lot of talking engagements. I just listened to you, and I recommend all the listeners here go and listen to the NYSEA radio podcast that you were on. It was very entertaining. I was listening to it on my way into work today. Just kind of talking about current injuries within sports, and I kind of wanted to just kind of go back a little bit and ask you a little bit of how'd you get into the career path of being an orthopedic surgeon, and kind of what drew you to ortho in general and the path that you took.
So first off, thanks for having me on the show. When I was a kid, I kind of thought I might be a doctor. And my parents were like, "Oh, you kind of act like, you think you'd be a good doctor or whatever." So I thought, okay, let me try this out and see the path I want to go on. So I shadowed a bunch of different physicians, kind of pushed in my direction towards surgeon just because of the ones I met, and et cetera. And then I kind of met a few particular orthopedic surgeons, and compared to some of the other different doctors I had seen, they seemed to fit best with me in terms of my athletic background and my kind of like strong desire to have like really, almost instantaneous gratification with the surgeries. So being able to take people, fix them, and 6 weeks, 3 months, people are ready or saying, "Thank you, I feel better." There's a lot of surgeries we do where in some cases you get that type of reward within, even a 6-week mark. And so I really like that. Or you give someone an injection, or you give them therapy, and they get better without, a long, prolonged course, which is what I think was really what pushed me that direction. And then really the patients, I love coming to the office, which is really fun on top of the operating room, because I enjoy my patients. They're active, ranging anywhere from that, like 15-year-old athlete to the 75-year-old ultra marathoner that's still doing crazy things from Seattle, So I really enjoy talking about the sports things, getting back in there, and that mentality. So that's kind of what drove me and what continues to drive me to enjoy the specialty I chose.
Yeah, that's a great way to get it started. And how we kind of came across each other was, I ended up working and sending you a couple complex cases. You did the third revision ACL with someone with a bone graft, and so I sent you a pretty tough one off the bat. But I know that you're kind of known and becoming even more known as we go along with some pretty complex procedures. You do a lot of, work on knee and then also shoulder sports injuries, but the specialty area seems, and maybe I'm wrong here, but complex cases of the knees, ACL reconstructions, and then also cartilage transplants and things like that. Tell me how you got into kind of being the go-to for the more complex stuff. Because I know you talked about, even on that last podcast that we mentioned at the beginning of the show, how a lot of your patients that are coming to you for these complex things, they've failed 2, 3, even 4 other surgeries from other surgeons.
So, the complexity came with the territory. So first off, I went to residency at a place called Hospital Special Surgery. So we saw patients from all around the world that came in there. It's the busiest orthopedic hospital in the country. And we kind of saw doctors that were at the top of their game, and they could take care of anything. And that was sort of the first thing. I was like, wow, there is a way to do this, but also have a thriving practice. The second thing was when I went to fellowship, I got to work with a lot of good surgeons, but the 2 top ones were Tony Romeo and Brian Cole. And if you're in the surgery realm, you know them very well. Brian Cole is probably the best cartilage surgeon in the country. Does some of the most complex cases and does them very efficiently. So, it's not, not schlepping in there for 4 or 8 hours trying to do, a simple procedure. He is very efficient and very good, and he takes care of lots of good athletes. So I saw that you could do interesting, very good cases, very interesting cases, very complex cases. You could do them efficiently, and patients still did well, which is always the concern, right? If you're doing a long surgical procedure, are they going to do well? If you're going to do multiple procedures, are they going to do well? And so I got to see that. And the same thing with the shoulder for Dr. Tony Romeo, and then elbow as well. So I do a lot of the elbow complex cases, especially sports related. So I saw that you could do that, and it was really fun. And I am sort of the person, a little bit of an adrenaline junkie, so I enjoy, the standard cases too. But for me, I really enjoy being able to push my skill set. I trained at pretty high level places, and I feel like I need to give that back to the community to be able to give that. Okay, I can do these cases because technically they're challenging. If you don't continue to practice them and try to overcome some, the stresses of doing these challenging cases, then that's really the most important thing. And you can actually help people with these complex cases because it requires a lot of practice to get to that level. And then once you get to that level, you want to be able to continue on doing that. So that's kind of, and then I think being a Seattle guy, like I came to Seattle with the understanding that, this is not a market where you can just show up and say, I want to just do simple, easy things. It doesn't work like that. It's very competitive. Orthopedic surgery is very sought after, and being an orthopedic surgeon in a big city is a very competitive market. And I knew the only way I was going to make a name for myself is if I took on the challenging things that people don't feel comfortable with. And that ended up being something that really kind of blew up my face in a good way. And now it's, I do the complex stuff, but I do lots of regular stuff too, which has been really, really fruitful and enjoyable.
Yeah, that's awesome. Yeah. And I mean, obviously, like all the patients that we've had that have gone and seen you have had great outcomes. And so every time we send people over, we always trust that they're well taken care of. And I've just appreciated, like, I follow you on LinkedIn and other social media platforms. I appreciate the level of education and talking about cases and really showing people that there is help out there for them, even with these complex injuries, which has been awesome. Let's jump into a little bit deeper into the cartilage damage and kind of like treatment stuff. My own personal history, I had a posterior patellar osteochondral defect. And when I was a college track athlete, I was a long and triple jumper. I had a microfracture surgery done to the posterior patellar surface, which I would say is was moderately successful. Tell us a little bit about, maybe people who have cartilage damage, what the options are. I know it's probably a pretty in-depth thing to cover, but maybe some general stuff that you're doing for these type of defects.
Well, first off, your defect is a challenging one. I would tell you of all the defects that we deal with, cartilage defects, patella is the most challenging. And in a high level athlete, it's really challenging. So you had, I'm glad you were able to get through it with that, but that's obviously something. So, but in general, we think of cartilage from a number of different standpoints. And this becomes challenging in the office too, because I have patients coming in and they're 30 and they say, okay, my surgeon said I have arthritis. The problem is that if you don't do a lot of cartilage, you see a cartilage hole or some edema or bone stuff on an MRI and the person has pain. You're like, yeah, they're arthritic, and you just wait for a total knee in, 10, 15 years. But I'm talking about a 30-year-old or a 25-year-old or even a 40-year-old. And that's too young to do a replacement. And so you got to look at it from a different standpoint. And we see these and we say, okay, there's actually a cartilage hole here and we're missing some meniscus, and I can actually correct these. And that becomes a different animal, but you have to open your eyes and understand what options are out there. When you come to that grip with that, there are certain things you can correct and certain things you can't. We look at cartilage holes. So there's small holes. Those are usually less than a centimeter. Many of those do not need treatment. And if they do need treatment, they're usually bigger than they look on MRI. So that's sort of the gist of the size. Let's talk about the ones that are bigger or symptomatic, because those are the ones that you guys want to hear the options for. The small ones that are asymptomatic, they don't need anything and they kind of go on with their life. When they become symptomatic, it kind of depends on where they are, what you do. But tend to, as you mentioned, it was interesting you mentioned the microfracture the way you did. I actually do not do microfracture anymore. The data is, when you had it done, and you're still pretty young, but probably 5 years ago or more?
Oh yeah, a lot more than that now. I would say probably 12, 13 years ago.
Yeah. So 12, 13 years ago, there were a lot more guys doing microfracture. As I told you before, I trained with Brian Cole. Microfracture is very limited in terms of what we do for it. We may microfracture, it's something like microfracture plus, where you microfracture the bed and then you add like a baby cartilage or some sort of cartilage thing on the surface. And that works okay. The problem you have is that, every time you do a surgery on a patient, if it fails, the next surgery is harder and the next surgery has lesser results. And so you got to be really careful when you start messing around with different surgeries or trying to do a simple surgery in quotations, because the microfracture success is around 65%. And to me, if I'm doing a surgery that's a 65% success, but I have a bigger surgery that's an 80 or 90% success, I'm going to have a hard time challenging that, because it doesn't look good for me either. If you send me all these complicated patients and they come back and you're like, you got a 40% of them are like, yeah, he's okay. I don't feel much better. That doesn't work very well, right?
Yeah.
You want to get the right thing the first time. So because I have the skill set to do the more complex stuff, I tend to lean towards the higher gold standard, but it requires more effort and energy for the patient and effort and energy for me, but really it requires more time for the patient. So you got that microfracture, which people can do, and I tend to shy away from it. But again, for smaller defects, occasionally it does work okay. And then for larger defects, you think about things like there's something called de novo, where you can microfracture, and then there's sort of disparticulated juvenile cartilage that you kind of glue in there, and that has reasonable results for moderate defects. And people do that for the kneecap as well. The options, there's some other newer things coming down the pipeline, but really the big two major cartilage procedures are MACI, which is where they take a biopsy of your cartilage, we grow it in the lab, actually in Boston, and then it gets flown back here and we glue it on the knee. And then the other option is a fresh cartilage transplant. It kind of depends where you're talking about in terms of successes, but those are the two main ones. We're always trying to think about scaffolds and fancy stuff, but those are the two main replacement cartilage things we have out there that are covered by insurance with good results. I don't know if you have any follow-up questions about that, but I'll stop there and let you continue.
No, I think that covers it pretty well. And I figured, that at the time my two options were some cartilage transplants, but like you said, the the time span of the recovery was a lot longer, because they said they would have to kind of basically take the patella and flip it upside down to get a good access point to it. And so that was kind of an option. Actually, funny enough, I had the exact same thing happen on my left knee. All I had was the cartilage debris removed from the knee, and that one ended up doing better, although it was a slightly smaller defect. But at the same time, now, looking back, I probably would have opted for the higher level one, because although I did get back to competing, I never got back to like where I probably wanted to training wise. But again, now with my PT and whatnot, I can move around pain free without any pain in the right knee. So I guess you would consider that a success for sure, and I consider it a success, which is awesome.
Yeah, no, I think that's really good. That last point you brought up is really important. I see people a lot of times, I scope their knees and I just do a debridement, and that is just as effective sometimes as a microfracture. You're like actually the perfect patient to bring that up. So just so people hear that, you don't have to have a second surgery sometimes. Sometimes the scope alone is treatment, because there's loose flaps. And so I have a couple of my talks on my website. You can take a look at those. It's the same data that you just mentioned. So it's just a really good point you brought up.
Yeah.
Sorry.
Awesome. No, that's great. And you kind of mentioned arthritic change and going down that pathway earlier. Is there anything you guys are doing as far as like early arthritic change, anything to help avoid that or stop that? Are you doing orthobiologic treatments for that, or do you see that being a viable option?
Yeah, so I mean, I do a fair number of talks on the orthobiologics for Swedish and Providence. So I tend to see a lot of patients that come in asking about it. The thing you have to think about is that the biologics are only so strong. So there are a number of biologics out there. The most commonly known one is PRP, which is where we take your blood and spin it down. It's also the least expensive option, which is also good because it's got the most data. There's the stem cells, and there's tons of different types of stem cells out there. And the ones that most people get is the amniotic fluid. That's like the Renew. There's a couple other options out there. I do bone marrow aspirate for some of my athletes. Those are more expensive. There's a little less data on them. There's also fat stem cells, which you can do. Everyone's trying to find the holy grail. There's not a lot of data that shows it reverses the cartilage changes, but it is a potent anti-inflammatory, and it does take away, people with early arthritic changes do quite well with those injections, and they can, continue on an active life. Again, my goal is, I love to prevent knee replacement, and that's what I do with some of my cartilage procedures, or try to, but our goal is really to buy someone more time. So if they need a replacement, which nobody wants to have one, it's not when they're 30 or 40, it's when they're in their 50s or 60s. So, that's the big thing to think about. We're trying to buy as much time as possible to hold off for the next technology.
Yeah, no, and I think things are advancing quickly, and that kind of brings me perfectly into my next kind of question is, where do you see the future of orthopedic surgery and sports medicine? And then, you mentioned a little bit of how it's changed as far as like the microfracture, but is there anything big that you've seen change or is currently changing in your practice, now comparatively to when you started practicing?
Okay, so here's an example. So in fellowship, I did not see 30 or 40% of the cases that I do now. And I was at Rush, which is the guys that are most cutting edge. And, I had all these crazy different things now that I'm doing that I wasn't doing then, and they weren't really out. So, big things are, there's a number of things. So first off, the future of orthopedics is how do we reduce the amount of reconstructions, ligament additions, everything else, and just repair the tissue we currently have. So that's the future, is like you tear your ACL, any ACL tear, can we fix it, get your old tissue back and not give you a new ligament, whatever it is, or you tear other parts of your knee. Cartilage, can we give you your old cartilage back or fill that defect again, etc. A lot of these defects, a lot of these problems with the knee come from other issues. So like they have an ACL tear, the ACL wasn't done very well, they re-injure, like, you talked to me about a couple patients you sent me, I get when I get in these plates, they've had 3 or 4 surgeries. Can I find a way to do either the best possible surgery first and reduce that from happening, educate, or have a procedure that helps that? So I've started doing we call them ACL repairs. It's sort of a newer topic, but basically we repair certain people's ACLs, and then the data on that's improved significantly to the point where it's almost as good as a reconstruction without the need to have to take down give you a new ACL. So I do those things. Can you add biologics? Can we realign someone's knee who didn't catch it early enough? So like I try to do things. So can I stop the process from happening? Are they out of alignment? Can I realign them, do some cartilage and help that? With meniscus, can we transplant scaffolds like I mentioned in that last podcast? So the future is more biologics, earlier treatments to reduce, earlier for shoulder dislocations, you have to be more aggressive. Maybe a first-time dislocator now gets surgery so they don't need anything else. So surgery is probably still an option in the future, especially even in the next 20, 30 years, but can we just do a much simpler surgery and therefore you don't need anything else ever again and augment it with biologics? So
yeah, that's a great way to look at it. And I haven't really seen anyone with the ACL repair. How many of those have you done? And what's leading your decision to repair an ACL versus reconstruct? And like, what are the factors that go into that?
Yeah, I don't want to harp too much on it, but I'll give you some quick stuff. And we have a podcast we did about it about a month and a half ago with from NYSE. But
okay,
basically,
we'll look that up too.
No, look it up. But I'm happy to get a brief update. So basically, certain types of tears, usually patients above 25 years old, the proximal, so the ACL is torn off of the femur, not off of the tibia, and it's not a mid-substance tear. So there's ones on MRI where you look at them and you can see the ACL still there, just like one attachment's off, and they feel loose on exam, and you get them within the first 3 months. Those are your ACL patients, repair patients.
Yep.
Some people are more liberal with their decision making, but the best data is on those patients particularly. So those are the ones that I'm starting with in terms of the repair. And I would tell you it's probably 1 out of every 10 to 12. We've probably done about 10 or 11 of these. The new system that was game changer for this procedure came out only like 4 or 5 months ago. So having had to see the system first before I believed that it was going to work well. The theory's been around for a long time, but this new system is so much better for repairing them. And I've been way happier with the technique. I've tried the technique before in the lab. I've seen other surgeons do the older techniques. It was just not as successful. I've done a lot. I've done revisions for those things when the technique was the old technique. This new technique is a game changer. And I think you're going to see even faster results or better results in the future.
Wow. Yeah, that's awesome. And typically I think where we start to see these newer things, and even in PT, we always see it happen in professional sports first, or like people trying to do the least that they can, and then it starts to kind of trickle down. That was the same with like blood flow restriction therapy when it first came out. There's a lot of NBA professional NFL guys that were doing it, and now most clinics that do post-surgical rehab should have those things. So thank you for the update, and we'll definitely link up the show notes or the show links for the NYSE podcast that you've done on those 2 topics, so people can go catch those. I want to be respectful of your time. I know we've only got a lot of time, so I also want to leave a little bit of time for you to tell people about where they can find you, which will also link up in the show notes. But just give us some information on if people are looking for an opinion on a knee or a shoulder injury or another elbow, where they can find you.
Awesome. So Very straightforward, www.grantgarciamd.com. That's my main website. If you look up my name, it's the very first search on Google. There's a few other sites that I have through work, etc. But that's the main one where all these videos are all put together nicely on certain sections. So that's the easiest way to find me, and that'll give you most information. It's organized fairly well. I try to keep it as up to date, but also not overload people. But we've got about 150 videos, as you might have seen, on surgeries, blog videos, podcasts. Just trying to make sure. I mean, the one thing I like what you mentioned before is I do a lot of regular surgeries, but I also do a lot of really complicated, stressful for patient surgeries. You know, three parts, 2 hours, multiple surgeries needed for this, and patients are really scared and they're confused. And they were told by another doctor, oh, not a big deal. You just need some little tweak here or there. Or they even had a surgery and they weren't even told the procedure. I want my patients, no matter what level of knowledge they have, and most of them have no medical training whatsoever, to come out of right before surgery, they know exactly what surgery I'm going to do. They know exactly the technique I'm going to use. There are no secrets in my operating room. There are no secrets in what I do. Every single one of my patients, at least I try to tell them, I teach them about what they have. And so they're like, oh yeah, I need a cartilage transplant, I need a revision ACL, I need a meniscus transplant. I get it. You know, I know what I need. You know, I still trust you as a surgeon to make the right decision, but it makes sense to me why you're doing this. And my patients' knowledge helps a lot. I mean, you see in some of those video testimonials, these patients are totally on board with this before we do it. It's never a discussion, you know, like, I think you need this, but I don't understand why I need it, blah, blah, blah. And they never usually, at least I try to make sure they don't question what I'm doing because their knowledge is there, or if they have questions, I answer them for them. I don't like patients that are confused as to what they're going to get done.
Yeah, and I've seen that, you know, firsthand. I can vouch for the amount of, you know, prep that your patient. I mean, your patients are coming in. Sometimes I'll get your note on what you're going to do, but they can recite it basically to the T, where it's like, you know, I have to get bone graft and then I have to wait this much time. And then what we're going to do is we're going to go and use this as the graft, and this is going to be the recovery time. And then, your website is just served for a really good resource, I think, for your patients, then also for physical therapists and anyone who's interested, because you also have all of the your protocols up in there, and then all of the talks you've done, tons of education. So, I really appreciate you putting that out there, because it does make our job easier. And I think that, you know, that's what we try to do at HiDef as well, is educate people on what the process is going to be so that they understand it, and then they can move forward with confidence. And that really helps the recovery process in general, is when they know what to expect and they know what's been done. So we definitely appreciate that.
Well, I do want to say, you said kind words about me, but I want to make sure on the podcast everybody hears that at HiDef, you guys have been amazing. You know, we work together. It's a team effort here. And he may say that, you know, some of his patients that he sent me did really well, but my part's, you know, an hour and a half, and your part's like 10 times longer. So, you know, these patients do well for a number of reasons, but it's about, you know, 20% me and 80% you. So I really appreciate it. And they've taken care of a number of my patients that were non-surgical or pre-surgery, and taken care of them and get them ready for surgery, and done a great job. So they're one of my top go-to physical therapy groups as well. So it's something for people to hear. You know, you're not going to go wrong with your decision on any one of these situations.
Awesome. Well, we appreciate your time again. I'm sure we'll be able to get back on another podcast eventually, as things continue to change, and there's so much stuff that we didn't get to cover that your expertise covers. So again, we appreciate it. We'll link everything up in the show notes. And people, if you need a second opinion, a first opinion on a knee, shoulder, elbow, and you're in the Seattle area, Dr. Grant Garcia is definitely the top option around. So go check out his website. And thank you again.
Well, thanks so much for having me, and appreciate your time, and definitely looking forward to do another one in the future.
Awesome. All right. Have a good one.
You too.